Hi, I'm Dr. Mike Milligan. I'm here with Dr. Tom Nabors. He was the founder of OralDNA and the chief dental officer for
Quest
Diagnostics, retired from both now. But we're going to go over the report and talk about a few in particular, cross the names out, so that you get an idea of what to do as you read these.
Yes.
So this is great information.
Thank you.
For you. So we'll have a close-up of that report, and so let's start to go over this. There's what is this? 1, 2, 3, 4, 5, 6, 7 of the bacteria are over threshold. What do you make of this report, Tom?
Well, first, Dr. Mike, thank you so much for the opportunity to help us all understand what these reports mean.
Okay.
As we look at the oral cavity, we need to be aware of a relatively new concept that is called inflammatory burden. What that means is that we need to understand inflammation from all of its sources as it relates to systemic health. So oral disease, cardiovascular disease, and many other diseases are of course associated with chronic inflammation.
Right.
And the mouth is
problems in the mouth, oral bacteria in the mouth, isn't just a local problem.
Absolutely.
It goes through
right.
your entire body and causes all kinds of, from pregnancy to heart attack and stroke to Alzheimer's and dementia to respiratory to some cancers to rheumatoid arthritis.
Exactly right.
And these are the bacteria that go through, and Tom helped develop the report.
Absolutely.
It shows us which bacteria.
Absolutely. And a little more in-depth background for our audience, and that is that one of the problems that we have had in dentistry, or oral medicine if you would, is trying to determine which of our patients that have inflammation in the clinical arena as to what is that connection between, let's say, cardiovascular disease.
Right.
I read an interesting statement just the past week ago from a CDC physician that said there are no average people. Thus, as we look at prevention and treatment, we need to understand the differences in people in order to correlate, let's say, risk for disease or for treatment of disease.
Right.
The reason I created this report was because the science had come to the point where we were able to recognize, let's say, an oral flora that was conducive for health and no inflammation in the mouth or in the body, and those microorganisms that were most associated, based on evidence, with oral inflammation, thus the bleeding on probing and bone loss and so forth. And also it turns out that these microorganisms are also the ones that cause systemic inflammation.
Right.
So at a cellular level, we understand microorganisms very differently today. We call this as a continuum of the, quote, specific plaque hypothesis, also the host immune systems hypothesis, and even today, the metagenomic immune hypothesis. What does that mean? Well, it means that as dentists, we have the ability today to differentiate those who are even at risk for disease, or at risk for cardiovascular disease, and versus those that already have periodontal disease or those that already have systemic inflammation. So as we look at this report,
and there are maybe 300 or more species of bacteria in the mouth, of which pretty much 11 or so are the bad ones.
From what we know today, let's even multiply that by a factor of 2 and say that there's over 700 different species representing billions of microorganisms that are part of, let's say, the normal flora.
Right.
And some of these are part of the normal flora, but things happen in the mouth that creates a shift from normal to, let's say, abnormal. And you are correct in saying that based on the weight of evidence, it's these microorganisms that are most associated with the development of periodontal disease, peri-implantitis disease, as well as, let's say, cardiovascular injury.
Right.
And the way that we created the report, too, was to look at the literature based on their relative risk for creating bone loss. And that's how we started looking at these microorganisms, because the literature clearly makes it evident to us that if we have specific microorganisms associated with periodontal disease, we can even project bone loss over time.
Absolutely.
And so we have in this report place them in based on their risk. So high-risk pathogens, that means that these microorganisms are most associated with bone loss. Moderate risk, most associated with bone loss, and then low risk. So an individual can take a report like this at any age and at any clinical presentation and determining the risk for losing teeth, the risk for losing implants, or the risk for, it turns out today that these same microorganisms that are associated with periodontal bone loss are also the ones that are really the bad guys in this world of systemic inflammation.
Right.
They travel to distant places, they literally infect the endothelium. They infect arteries, and in such, they cause arterial damage. And that's really the connection between these microorganisms and arterial damage.
Right, okay. All right, so let's take a look at this report here. And let's just go over this one.
Sure. Well, I think that's great, and I appreciate the opportunity. So let's use the large term inflammatory burden. And if we looked at an individual that was healthy, no clinical signs of periodontal disease, we would not see any of these, very few of these, and these columns would be very low even if we saw them. And so we know there is a significant difference in the bacterial burden in an individual that has no disease, no clinical signs of inflammation, versus an individual that has even early signs. And based on pocket depth, this is irrelative at this point in time to pocket depth. This can be a 22-year-old that is just now establishing a bacterial burden that is going to lead to, or this could be an individual that has 6 and 8 millimeter pockets. So we can use this as a predictive tool. Let's say we're placing implants in an individual, and we're not really sure when the right time to place the implants because this individual lost some teeth, and we're going to place 4 implants in this patient's mouth, and we do this report. Would you place an implant in anybody that has this bacterial burden? I wouldn't. And so I would want to treat, regardless of the traditional signs, I'd want to make sure that these bacterial loads are down.
This particular patient, I can tell you, had a lot of periodontal disease. The next one I'm going to show you, clinically, had nothing.
There you go.
So
there you go.
But let's talk about this one. This particular person came in with 8, 10 millimeter pockets, bleeding, pus.
Yes. So this is a perfect example of what we call polymicrobial diseases. We have microorganisms that have shifted. They've shifted both in quality and in quantity. So we have microorganisms of 2 different types. When we look at this AA, or the Aggregatibacter actinomyces commons, it is a facultative organism. So as we treat it, we need to realize that it can live in the presence of oxygen or in the absence of oxygen. So our treatment strategy needs to be make sure that we are targeting that microorganisms to eliminate it. The risk for having this microorganism in your mouth over time is so high. We want to eradicate this microorganism, get rid of it completely.
You want 0.
At 0 on that.
Not just below threshold, 0.
You want to get rid of that one. This has been associated everything from brain abscesses to increased risk for heart attack. Same thing is true with this one here, the Treponema denticola. It is a spirochete. It is a cousin to Treponema pallidum. Of course, we all are aware of syphilis and the tertiary stage of syphilis and what it can do to our brains. Well, we don't know all of that potential power of TD, but we do know that it is a treponeme. It's a very powerful microorganism, difficult to get rid of, but we want that one gone. I don't want anything in my mouth that is associated with a treponeme. Get rid of it.
Absolutely. Judith McCloskey, we interviewed last year, and the international Alzheimer's in Switzerland. The head researcher there, and she said 6 types of spirochetes can go directly from the mouth to the brain. They've shown that.
Absolutely.
You want to get rid of that one.
Absolutely, you do. And as she was saying in her lecture last year, and it was so clear as she looked at radiographs of human brains with treponemes embedded in the brain, and they had dementia or they had Alzheimer's disease, that these are really bad players. And now that we know that the mouth is a source of that, certainly we're dealing with a systemic ramification, not only vascular disease, but also mental health. And these microorganisms, as we're learning today, and actually we're going to speak about today, have a huge influence on the other microorganisms in the mouth. These microorganisms here can turn traditionally good bacteria into bad bacteria. They change the pathogenic potential of the entire bowel mass. So while these may be typically healthy associated bacteria, look at how they have changed because these are present. So your goal is always to treat the highest risk microbiota regardless of number and get rid of them as much as you possibly can and watch these go down. Right. Because they will. And so bottom line is you have massive inflammatory burden here, massive systemic inflammatory burden as well. So our goal as dentists is to make sure this becomes our target. When we look at the literature from Journal of Periodontology, Journal of Clinical Periodontology, we now have two goals in dentistry. Okay. And we should, and particularly periodontal disease, we should have clinical stability. We're aware of clinical stability because we know how to use probes and we know how to look at tissue. Right. So, but here's the other key, and this is published in 2012. Clinical stability and microbiological stability. Why is that true? Because in this study, they clearly showed that 1/3 of their patients that they treated ended up as refractory disease. Guess what? Why were they refractory? Because their treatment didn't resolve this condition here.
Right. Even though they were clinically looked
Even though they clinically look good, that's exactly right.
They grew.
So
multiplied.
Our goals in dentistry, or in periodontal therapy today, are clinical stability and microbiological stability. Yes. That so happens to be the reason that we also want to look at this as a systemic ramification, because when we eliminate the oral inflammatory burden, that's the best we can do as a dental health provider. That's our job, is to make sure that the mouth is not a source of systemic inflammation.
Absolutely, yes. Yep.
So this report provides then our ability to define the disease based on the molecular patterns of these microorganisms here. Right. And then we treat the disease, and ideally we go back and do a second report. And that way we can determine that we have done our job. Right. And it's okay if we haven't accomplished all of our goals, because that will happen. It means we haven't stopped. In other words, what is the end point of therapy? We used to think the end point of therapy was the conclusion of our procedures. So we do 4 quads, that's the end point of therapy.
Right,
yeah.
Not anymore.
Not anymore. The end point of therapy today is the elimination of this as a source, and this will take care of itself.
Okay, and you say
yes.
that, and you told me that you may not be able to totally eliminate these, but you do your best and you continue to try to eliminate them as much as
absolutely, and this comes into the world. I know that there is different opinions about systemic antibiotics, whether to use them or whether to not use them, but I think we all should be aware of the literature, even as we will present today, of double-blinded placebo-controlled trials that clearly show in healthy individuals that systemic antibiotics work much better than our traditional model of scaling and root planing to accomplish this goal, not only in healthy individuals but also in type 2 diabetics. Because an inflammation, of course, in type 2 diabetics is a serious injury. Right. It's a serious potential for aiding their diabetes and this bidirectional relationship. So both in individuals that don't have diabetes and individuals that don't have vascular disease, this is still incredibly important as a source of preventing systemic inflammation. Okay. But I would also say individuals in your practice that have a history of vascular disease, that are diabetic, we should seriously consider systemic antibiotics, or whatever way that we feel is the right way. If it's lasers, if it's trays, if it's some kind of medication, make sure that we test our system by running these reports.
Right, so pre-test and then
pre-test,
post-test.
Yeah. That's the medical model.
So have we covered this? We're going to go
absolutely.
Through 2 more of
good.
These. Now this person came in, clinically they look good, radiographically nothing, 41-year-old man, and
incredibly revealing.
Bleeding, there were only a few bleeding points. There were a few 4-millimeter pockets. That was it. My hygienist said, "Why would you run an oral DNA test on this person?" I said, "Because we don't know what bacteria are in there."
There you go.
And so we found, what is it? It's 7.
It's incredibly important.
7 over threshold.
Give me a little history too. Is this patient, by any chance, does this patient have any systemic disease, a history of heart?
Referred to me by a local physician because he had just been diagnosed with diabetes.
There you go.
And the physician was smart enough
There you go.
to,
Yes.
to,
Yep.
to refer him to me for to see if there was any oral source.
The one thing that I've learned in the past four and a half years is that our bodies can change dramatically in short periods of time.
Mm-hmm.
And individuals, though, that are pre-diabetic, sometimes it takes 10 to 20 years before the clear definition of diabetes is there, or pre-diabetes is there.
Mm-hmm.
So we have an astute physician that understands the inflammatory burden that could come from the mouth that may contribute to systemic inflammation, insulin resistance, and pre-diabetes. So now we have a perfect marriage between medicine, let's say general medicine and oral medicine, where we are defining disease at the molecular level as opposed to just the clinical level. Because if we had been asked to write a statement based on clinical signs as to whether or not this patient is healthy from a periodontal standpoint of view, we would have been happy to sign our name that this patient can have a joint replacement, as an example. Or this patient doesn't need our help in the diabetic world. But when we run these tests, it's clear that the inflammatory burden of this patient is off the chart.
Exactly.
And P. gingivalis is such a strong connection to systemic diseases.
Mm-hmm.
And so when did this happen? We don't know at what point in time that this patient's molecular patterns in their mouth changed significantly. All we know is at this point in time, this patient is at risk.
Right.
Now, we want to make sure, too, that we add in the genetic factors, which we are not measuring here, but there may be some genetic factors associated with that. There may be also some other factors that are associated with, such as, I wonder what this wife's pattern looks like.
Sure.
I would like to ask the question, where did this come from? And maybe we'll never find that answer, but maybe it can transfer spouse and spouse.
Or child and
child to parent, and parent to child, absolutely. So again, our goals are the same. If you notice, the patterns here are similar but different. There's no AA in this patient, but there is PG and there is TD. This is similar, but the other one didn't have PG, but the other one did have AA. There's a little AA there, but it's not as much as the other. Again, what is our goal? Clinical stability and microbiological stability. We already know we're dealing with systemic condition here, but our goal is to make sure we have reduced the mouth as a potential source for systemic inflammation. So we use this test to create a pattern or a treatment model with the end result of making sure that we've eradicated these pathogens here and that we have reduced these significantly so that we don't have an inflammatory burden in the mouth. Our goal is not to sterilize the mouth. That would be very, very dangerous. Our goal is to recolonize the mouth so that we are populated with good bacteria and not bad ones. And these are the ones that are most associated with being bad.
Okay.
So this is what we're trying to change, because the good ones will repopulate faster than the bad ones, and then they can help resist or help control the repopulation of these.
Just like getting the weeds out of your lawn. If you have a wonderfully strong, solid lawn, the weeds can't grow there.
That's a really good analogy there. And we want to get rid of these weeds in this mouth to make sure that this patient, that we've done our job in making sure that the systemic health of this patient is consistent with what we now know is good oral health and good systemic health.
We all set with this one?
All set with that one too.
Okay.
Yep.
This is me.
Okay.
Now.
Yes.
I'm a patient of Amy Dominguez.
Yep.
Amy and Brad. And so and thankfully so.
Yep.
My family history, my father and my uncles died early, young, of heart disease. So as soon as I met them, I became their patient. Got my brothers to become their patient. Got other people to become their patient. And I don't worry about heart disease. They guarantee you won't get a heart attack or stroke if you follow their recommendations. Well, in my most recent blood test, my LP plaque 2 score, my inflammatory score, was a little higher than she wanted. She said, Mike, I know we've tested this before, but let's just test again, be sure that anything in your mouth can't be causing this inflammation.
There you go.
So I went ahead and, I did a full set of x-rays to be sure I didn't have any periapical lesions, no abscess teeth, and then I also did the oral DNA test, and let's see what my mouth showed. My name is on it. I didn't cross that one out. It's right there. This was just a few weeks ago.
Well, again, this is a perfect model of where we can use technology to understand even, let's say, minimal disease.
Right.
And can minimal disease be systemic in nature? In other words, can minimal bleeding in a person's mouth actually be a reflection of what we would call subclinical disease?
Right.
That's new for us. See, we always thought that periodontal disease was when bleeding occurs and when bone loss occurs. In fact, we typically don't even treat periodontal disease unless there's bone loss.
Right. And I don't have any bleeding, and I don't
Right.
have, any active
That's
periodontal
right.
lesions.
Yeah.
My mouth's healthy.
There you
Okay?
go. Right.
I take good
But is
care.
it possible that we can have a healthy mouth and then see pathogens and we have actually subclinical inflammation?
Right.
The work that I did over the past 30, 35 years was to look at individual microorganisms originally and look at the research behind them and look at their pathogenic potential. Even at low concentrations, we find that some microorganisms on their own have the ability to be very, very pathogenic. But we also know that there is a symbiotic relationship between all microorganisms, and that when we get a particular microorganism, and we're calling them keystone pathogens today. Why is that? Because their influence over other pathogens, as well as their influence over, let's say, commensal or core microorganisms, is so powerful. It's like building the Roman arches. There was one stone that was most important, and that was the key stone, because the key stone held up all of the other stones in the arch. Well, now we're discovering that there are certain microorganisms in the gut, as an example, that are, quote, keystone pathogens, such as, let's say, E. coli. Well, we have E. coli normally, but when they become excessive, they become keystone. And what do? They influence the entire community of microorganisms. They change the quality and the quantity of the microorganisms that are there. And the keystone pathogens turn good microorganisms into bad microorganisms and totally changes the gut microflora. We end up with Crohn's disease, we end up with gastric diseases and so forth. So part of our treatment today, let's say the gut microbiome, is to restabilize the gut so that we get normal function. Same thing is true here. Thus, when I look at you, there is not so much potential of your losing your teeth, what that used to be our objective for, let's say, treating periodontal disease, but there is some potential for systemic inflammation.
Right.
And as Dr. Doneen has done, she has looked at your plaque 2 and determined your plaque 2 is elevated, and it's possible, based on the research that we know today. In fact, plaque 2 is elevated by only one or two different things, and periodontal disease is one of the things that elevates plaque 2, and it can be subclinical. And so if I were you, I'd want to eradicate AA, and I'd want to eradicate TD, even though the threshold has not been breached.
Right.
In you, because there are no average people, it is possible that your immune system is overreacting, if we would say, to the inflammatory burden, even though it's low. And even though we don't see a lot of bad players here,
Right.
I would be very interested in knowing, once you treat yourself, have someone else treat you, by the way, don't treat yourself, and then we'll see what this inflammatory burden, and please keep me abreast as to what this does and also what your plaque 2 is after you do that.
Right. So it was just very interesting to me.
Yes.
It's very low.
Very low.
And yet Tom said, "Oh, I want those down to 0."
Absolutely.
Whoa, okay.
Absolutely.
Let's get those down to 0, and then I've just got the 2 to the right here that are over threshold. And he says, once we eradicate these, let's see
Yes.
what happens to these over here. And he said, now the particular antibiotics you talked about were amoxicillin to
Yep.
eradicate at least the far left one.
That's correct.
The AA, and then he wanted the
Yes.
metronidazole
Yep.
to eradicate over.
One of the difficulties that we've had in our profession is, number one, deciding if we're going to use antibiotics, and then when, how long we're going to use them, and more particularly, which antibiotic is most appropriate. And so these tests, when I developed this whole model here, I also looked at all the literature that related to systemic antibiotics based on the infection, because that's a responsible way of using antibiotics.
Right.
To give you an example, the double-blind placebo control that we will show today looks at 3 different antibiotic regimens. One is metronidazole on its own, The other is amoxicillin and metronidazole, and the other is our old standby of doxycycline, which many people are still using. And it'd be very interesting for us all to look at those antibiotics and to see what the ultimate end result is when we use them. And the point is that if we don't target the right antibiotic for the right infection, we're wasting our resources, and we're potentially exposing the patient to antibiotic resistance in ways they shouldn't be exposed to.
Yeah.
And so
you don't want to use them if you don't need them.
Absolutely right. So be very cautious in using antibiotics, and if you don't have to use them, that's great. But if you do have to use them, use this report to define the antibiotic regimen, and you will be on safe ground, and I would make that recommendation. Be safe.
And the amoxicillin,
Yeah.
you said to use for which particular
Yeah,
and the metronidazole, and why?
The way we broke this out was to look at the virulent properties or the pathogen potential of each microbe itself. And as we all know, gram-negatives have to live in the absence of oxygen.
Right.
So they tend to be subgingival, where they isolate themselves and they manufacture their own environment along with the other microbes that are there. But then we have some in the mouth too that are both anaerobic and facultative. They can live in the presence or absence of oxygen. Right. And the way that our antibiotic models have been created, we have antibiotics that target, let's say, gram-negatives, gram-positives, and facultative. So when we have a true mixed infection that includes both gram-negative microbes and facultative microorganisms, we can expect a single antibiotic that's really designed for, let's say, gram-negative to affect the facultative. Right. It won't. And so then we have to use our two-shotgun barrels in order to make sure that we have created an antibiotic regimen that targets both gram-negative and facultative. And the interesting thing about using the cidal, and that's another thing, we use narrow-spectrum bactericidal medications as opposed to broad-spectrum bacteriostatic. Bacteriostatics don't kill, simply inhibit the reproduction of microbes. It certainly helps for a short period of time, but cidal medications are designed to kill. And that's what these reports are really designed around. Narrow-spectrum targeted antibiotics to get the effect that you want, with as least damage to the rest of the oral flora and the gut flora as possible. We always know that there is going to be some damage, but what we are seeing in these reports and in the studies, these double-blinded studies, is that patients can go through a short term, such as 8 to 12 days, and I prefer the 8 days because that exposes them for less period of time. And in your particular case, certainly 8 days would be appropriate. On some of the others, you may want to extend out to 10 days or 12 days, depending on the severity of the infection and the history of the patient.
Great. Is there anything else you'd like to tell us about these reports while
Well,
we've got you?
First of all, thank you for the opportunity to talk about such a revolutionary change in our ability to look at the biology of disease versus the anatomy of disease. Yes, we need to understand the anatomy of disease. We can see it in the mouth. Right. The mouth is very easy to see. But we also have to understand the biology of disease. We have to understand the human microbiome, the oral microbiome, the genetics, all of those factors. And what we are learning, and as we see these reports and case histories, is that we have taken the role of the dentist and the dental hygienist into real oral medicine. We're not only treating teeth and implants and saving teeth and implants, but we're also making sure that we are a real partner in health care. And now we are working with physicians, as you are here, and we are on equal footings. But the clinical laboratory is what's brought us there. Right. And it's the microbiology information that has brought us there. And thus we have to be able to look at the biology of the disease to understand the systemic influence. So thank you for the opportunity to visit with you, Mike.
Absolutely. And I've got one more question
for
you.
Yeah.
We do have dentistry now has the ability to do just a little finger stick.
Yes.
And test for things such as LP plaque 2, an inflammation marker, HSCRP, an inflammation marker, and A1C, a diabetic marker.
Yes.
How do you feel about those, the importance of that, and the dentistry doing that for their patients?
Well, that's a wonderful question, and we have good studies from, let's say, Buffalo, New York, and so forth. Particularly our editor of the Journal of American Dental Association, Dr. Michael Glick, has been very, very outspoken over the past decade and a half on dentist screening for systemic disease. And I think that we should be knowledgeable of those types of tests. It's a non-invasive test, a finger stick, anybody can do it.
Right.
It's very easy, and you send in a card and you get reports, so it's wonderful information. I would say we need to learn about that as clinicians, but more importantly, we need to have a partner in the general medicine world that we can refer these patients to.
We can screen, but we need to have them to
absolutely,
refer
yeah.
to help co-manage the patient. We can manage the oral health.
Absolutely. We start getting into very close proximity to medical treatment versus, let's say, oral medical treatment when we start running these tests. And we want to be very sure that we are not crossing over, let's say, licensure boundaries. And that's not, getting that information, but using that information, should be used by, let's say, a primary care doc or internist or whoever you're working with. And I think it's wonderful that we can get that information, but I think we also need to be very careful that we have these relationships. We can be involved and should be involved in detecting prediabetes. We should be involved and can be involved in detecting early signs of vascular disease. And that's what this test does. They don't have to go to a laboratory to get it done. They can have it done in the dental office. And those
just like we do a blood pressure.
Just like we do a blood, absolutely.
Screening.
So I would encourage the audience to look at this Heart Smart screen test, but learn about it, go to a course, find out how to connect the dots to make sure that we are giving the patient appropriate information and the appropriate therapy follows after that.
Right.
So it's a good test.
Dr. Nabors, thank you for all you do, and
thank you, Mike.
So much for being with us.
Well, thank you for having me. I appreciate it very much.
Okay.